Jin Tiong, thank you for the kind introduction. Hello, everyone. Good evening. I would like to firstly thank the organizers for a wonderful online symposium so far, and my congratulations. And thank you for having me to share about our experience with Biobot. Um, so firstly, I'd like to share some photos of our hospital, which is ever expanding. We are increasing the number of buildings all the time. So the NUH is full of, it's a conglomerate of many buildings spaced over quite a big area. These are my disclosures. So as Lincoln has very nicely alluded to already, there are some, while TRUS or transrectal systematic biopsy is the traditional standard of care, there are a number of issues that are well recognized, such as a false negative rate, a undergrading, meaning that there are basically, it detects clinically insignificant cancer because it's non-targeted and is in somewhat random. And of course, there's also concerns of the transrectal route in terms of the issues of infection and sepsis that has been already mentioned. And of course, more often than not, when we do a systematic biopsy, we have to be prepared for at least 1 or 2 more repeat biopsies. So as Lincoln has very nicely alluded to, actually Lincoln was part of the NUH team that started off the transperineal biopsy with precision point under local anesthesia in 2018. We were one of the early adopters in the region, and Lincoln was part of one of our early proctors who started together with us the early cases that we did what already has been described. And NUH has since then become a training site for the transperineal precision point biopsy under local anesthetic that we started some other hospitals on, and we are happy to say that we are very willing to share our experience and the technique. And Lincoln is also continues to be part of our faculty. So the second limitation, aside from sepsis, with regards to the transrectal route, has got to do with the limitations of the fact that any prostate biopsy that's systematic is non-targeted, and therefore it's kind of a game of chance. If you biopsy the prostate at any one time, the needle only covers a very small portion of the prostate, and very little of the prostate is actually sampled. And that's why there's such a huge move over the last decade into MRI. And it's good to say that we have standardized reporting in the form of PIRATES. Now it's currently, if I believe, version 2.1. And because of that, there's been a lot of progress in the role of targeted biopsies, namely using MRI to fuse and co-register with the real-time ultrasound, especially to do a targeted biopsy. But of course, in terms of MRI utility, there are a number of ways that you can target a lesion. The simplest way, of course, would be a cognitive fusion, where you kind of have the MRI lesion on the MRI in your mind, so that you aim the needle towards where you think the lesion is likely to be. And of course, this usually is suitable more for a very large, a relatively large lesion on MRI. And then, of course, there's the MRI to MRI, what we call in-bore fusion biopsy, whereas this is done real time on an MRI machine. This is rather cumbersome and is actually very difficult logistically. What is most common is the MRI ultrasound fusion, where it's actually a software co-registration of the stored MRI image with a real-time ultrasound, so that you can actually you can fuse the MRI image with the ultrasound to achieve a targeted biopsy. Now, there are a number of different platforms, and already Lincoln has alluded to some, such as the UroNav, and then there are so many other platforms. But of course, they also employ different routes of biopsy, ranging from transrectal to transperineal, and some platforms are more versatile to be able to accommodate both transperineal and transrectal biopsies. And at this current point, there is no less than 10 platforms out there in the market, or probably even more as we speak. There are so many platforms that the question is, which do you choose? But rather, I think a more important question is, which are you more comfortable with? So the common indications for MRI fusion biopsy are those with patients who's never had a biopsy but has a clear suspicion of prostate cancer, namely through the DRE or abnormal PSA. And of course, those who had previous negative, usually a systematic 10 to 12 core biopsy that requires a second biopsy. And what's emerging is also the role of MRI fusion biopsy in active surveillance or for focal therapy planning and follow-up. Now, there are a number of, when we talk about MRI fusion biopsies, there are a number of biopsy strategies at this point. There are those that in some practices, MRI targeted alone is done, and these are done in practices that are very established and they have very strong confidence in the team that reads the MRIs and as well as the platform, such that they feel that there is no need to do a systematic biopsy. What's most common is for those who do MRI targeted plus a systematic, which usually comprises 10 to 12 cores of biopsy. And what is not so common that we do, which I'll explain later, is an MRI targeted plus saturation biopsy. And by saturation, the standard definitions is beyond the 12 core biopsy. And usually it has to do with the number of cores really correlates with the size of the prostate. Now, although there are a few trials which will show later, but one of the important trials that I would like to show to set the stage for the reasons for MRI fusion biopsy is the precision trial. Of course, there's the PROMISE, there's the 4M trial, and the MRI first trial. Now, very simply in this simple cartoon diagram, I want to show what is the precision trial trying to show. These are in patients who are the standard patients that you usually refer for prostate biopsy, abnormal PSA, some people who have at risk, that you think at risk of having prostate cancer. Now, in the control arm is the standard way of how we do a systematic 10 to 12 core biopsy. And if you look at the end result, you will see that they define clinically significant cancer from grade group 2 and above. That means Gleason 3+4. And their diagnostic rate from the standard traditional biopsy was 26%, but they also found insignificant cancers in 22%. Now, if the patient underwent a MRI directed route, that means they had patients who are MRI, who had abnormalities in the MRI, meaning that PIRATS 3 and above, they would go for a targeted biopsy. Now, in the precision trial, they also went for standard systematic biopsy aside from the targeted biopsy. And their diagnostic rate for grade group 2 and above, the significant cancers was 38%, more than the standard arm, about 26%. And they had lesser insignificant cancers, about 9% compared to 22% in the standard arm. So what they concluded was that doing an MRI targeted approach would give you more diagnostic yield in terms of clinically significant cancers, while you have lesser over-detection of insignificant cancers. And in that sense, if you use this strategy, estimated a quarter of men may actually avoid the biopsy. Now, what's being shown in what is the current EAU guidelines? The current EAU guidelines do not recommend MRI as a screening tool, but those that you think has a risk of detecting prostate cancer, such as in abnormal PSA, they would recommend doing a MRI before doing a prostate biopsy. And this is for both biopsy naive as well as for patients who had prior negative biopsies. So the evidence for this is strong. And if the MRI is positive, which is defined as PIRATS 3 and above, it's also strong evidence in the EU guidelines to suggest that for biopsy naive patients to combine a targeted and systematic biopsy. Now, what is a little bit different in those who had prior negative biopsy is that if there is a positive lesion, the EU guideline recommends at least a targeted biopsy. It's a weak recommendation because they do not include systematic biopsy. In other words, it's not so much that basically, in other words, they are recommending at least a targeted biopsy. Now, at NUH, in my center, we've been using the Mona Lisa, we call the Biobot, as a platform for MRI ultrasound fusion targeted biopsy since 2015. This is probably the only robotic biopsy device in the market, and it's totally automated, and it's a very nice device to use. We do this the biopsy is done transperineally perineally under general anesthesia. The reason for general anesthesia is because because there is a robotic motion, and we prefer the patient to be absolutely still when the robot is moving and targeting the system, so that there is less chance of needing to reposition. Of course, some may recognize that, some may view that as a disadvantage. However, so far in our series, almost no patients have ever complained to be under general anesthesia. Of course, there are pros and cons to that. Now, so in terms of patient positioning, as already alluded to in the last talk and discussion, we put this patient in high lithotomy to precisely bring the pubic arch away, so that there is actually very little chance. If you do this, there's very few times that we cannot reach the anterior lobe, or there's because this brings the pubic arch out of the way. Now we mount the robotic, the Biobot is a Singapore-made device. We pair it with a standard BK transrectal ultrasound probe. It's a biplanar ultrasound probe, and we normally what we do is we actually position the patient, clean and drape, and then we will insert the Biobot rectal probe device. This is what the device will look like. I'm going to show a short video because I think it's easiest to see. This is a video prepared by the Biobot company, so I'm just going to show briefly how this Biobot is being introduced into the patient. So there is a movement of the probe into a sheath, a transparent plastic sheath, and at the same time, this basically helps. The robot is being positioned. There is a needle depth control, that a piece of metal here that prevents your biopsy gun from going too far in, and that tells you the depth of how far your gun can fire. So this sheath is designed such that it will reduce the movement or compression to the prostate, so that there is very little deformation of the prostate during the movement with the Biobot. And this basically the movement is robotically controlled, and you have so as you can see, if you want to target, there's a region of interest. Basically, this is pivoted around the skin at 2 targeted points. Okay, we move on to the next slide. So basically, what we do is we after the Biobot is introduced with the rectal probe into the patient, we actually proceed to scan the prostate in a 3D fashion. The ultrasound probe will move along that transparent sheath that you saw just now, and it automatically scans the whole prostate. And what we do, the physician does, is they will show, the image would show a number of several cuts of 2D pictures transversely, which we will draw. You can see the physician, the urologist will physically draw these to delineate the prostate where you think the boundaries would be. And then next comes so this, and the software will actually give you a 3D picture of what you have drawn. And then the MRI in pink, then this is the MRI picture that has been pre-drawn by the radiologist, and this is in pink together with the target lesions that we're interested in. And then the software does what we call elastic fusion between your drawing and the MRI drawn picture. So you're able to review that. So if you find in some way that your drawing seems to be very different, you can actually review and redraw where you think the prostate boundaries are. So that achieves a co-registration in terms of elastic fusion. And then comes the core planning. So since using this device, we have actually adopted a targeted plus saturation biopsy approach. The reason for that is because since the patient is under general anesthesia, we take opportunity to do more cores with the hope that there is actually, we hope to reduce the number of repeat biopsies for every single patient. So what we do is after the fusion, after the elastic fusion between the MRI picture and the real-time ultrasound, we plan the targeted cores first, and where we can see not just, if you can see this software is nice because you can see both a 2D and a 3D picture. So you have a view of how long the core is, as well as whether you're going to overshoot or biopsy pass or not. And then you can plan in terms of safety, you can actually prevent the pass pointing of the needle. So in planning the course, this is the targeted course. After planning the targeted course, we go on to plan the systematic or saturation course. So there is option to do systematic 12 core as well, and it's very much up to the operator to decide how many cores in the rest of the prostate you want to take. Our habit is to determine that based on the size of the prostate. So in a bigger size prostate, we'll take more cores, and with this 2D planning on the right, we can actually plan it to space the cores well distributed for the rest of the prostate. And so I'm going to show a video because it's rather difficult to show how the Biobot actually works in real time in a real patient, because you don't really see where the trajectory of the needle is. So using this model, I wanted to show how it actually works. So if you can see after you start planning, the Biobot is automated on its own after that. It will move and on its own, and basically what the needle is the needle is actually pivoted at the perineal skin. So we end up with two needle points, one on each side, the right and the left, and the Biobot will actually angulate to target the lesion that you want based on the point of angulation is at the perineal skin at the point of entry of the needle. So once the robot has actually shown where you want to target, the surgeon will insert the needle and does the biopsy. With the guide there, you can see here, the guide will actually prevent the pass pointing of the needle. So this is in real time. We will see where there's movement of the Biobot. You can see that in blue, that's our target, and the surgeon proceeds to fire the point. You can see that in real time, you can actually monitor to see that actually whether the needle actually hits where you plan it to be. So, and then next, we move on to the next one. The blue has shifted to S20, and that's where we plan the target, and the surgeon will fire. And in real time, you can see that the shadow shows that we actually hit where we want to hit. So in that sense, this is a fully automated system that is very easy to use and is actually very user-friendly. So after the procedure, you will see there are only two needle points, one on the left and one on the right. Even if you did multiple biopsies with a saturation biopsy, you still end up with usually two needle points, because the needle is actually pivoted at the perineal skin level. And how the different sites of biopsy is achieved is that the Biobot will actually angle around this point. So to share our experience, we've done over the 4-year period, we've done 240 cases. Of course, we've done more by now, but this 240 cases are what we use to report the results. Most of them are biopsy naive. We have 73 patients who are previously negative, and we have a number on active surveillance protocol that we subject to this as a confirmatory biopsy after the first biopsy diagnosing them to be low-grade or low-risk cancers. The median age is 67 years. We have a median PSA of 78, and our mean prostate volume is about 50 cc's. We had per lesion, it depends on the size of the lesion. If the lesion is bigger, sometimes we take more cores, but the mean target cost is about 5 per lesion, and the saturation cost on average is about 29.8.
Edmund, I think we lost you on the screen.
Hello?
Hello?
Edmund, your screen is frozen.
Yes, sorry, can you hear me now?
Yeah, we could.
Yes.
Can we request you to give us your maybe take-home messages, Edmund? We are a bit tight on time.
Okay, I'm finishing soon.
All right, great.
So sorry for the connection problem. So in terms of our biopsy, I put I'm sorry for the busy slide, but in terms of targeted and saturation, our diagnostic rate for naive is about 56%, and negative biopsy is about 55%. And if you look at only targeted biopsies, basically our diagnostic rate for targeted biopsy is rather high. In terms of insignificant cancers, it's somewhere between 9 to 12% for biopsy naive, and that compares well with the precision study. So in terms of grade group 3, grade group 2 and above, basically the diagnostic rate is about 38 to 48.6% based on whether you add a saturation biopsy. So in terms of grade group 3, actually you realize that our targeted biopsy seems to be doing well, because whether you have saturation biopsy or not, there's no difference. In terms of PIRATS 3 and above, the higher the PIRATS, we have a higher diagnostic rate, especially in grade group 2 and 3. If you compare the EA, these are my last few slides. If you compare the EAU meta-analysis and the Cochrane analysis, basically for biopsy naive for grade group 2, our series have a higher at a high end of diagnostic rate compared to all the other series. And in negative biopsy, also we achieved 37% compared to 22.8%. And here, similarly, in grade group 3, our diagnostic rate is considered pretty high compared to the others. At the same time, we also do not diagnose too many insignificant cancers as even compared to the precision point. In terms of complications, our Biobot series, we have a small percentage of UTI, and we do have sepsis in a small percentage because some of the patients, one of the patients declined insertion of catheter despite high residual urine. There is a higher catheter insertion rate, but the true retention rate was 2.1. The others were people who had high post-swap residual urine. And this is in comparison to our historical TRUST biopsy series of higher sepsis rate. And if you note, there's a big difference in terms of the antibiotic prophylaxis. The transperineal that Lincoln talked about, we hardly use antibiotics or oral antibiotics, and our sepsis rate has been low, but except for one patient who had previous history of bacterial prostatitis. So in conclusion, we now have better map and better tools, and we are able to detect more clinically significant prostate cancer with MRI fusion strategy, while actually lower the detection rate of clinically insignificant cancers. It's uncertain whether we can do away with systematic biopsies at this time, but in our series, the Biobot achieves at least a comparable clinical significant cancer detection rate compared to what's known in literature, and seems to have a reasonable morbidity. Thank you very much.
Thanks, Edmund. Okay, so a few questions quickly because we are also running out of time. First question is, you mentioned about the MRI in-bore biopsy. I think very few of us have any impression of what it's all about. Do you have any experience on the MRI in-bore biopsy? Oh, I think we've lost Edmund. Hello, hello. Edmund, are you there? Hello?
We've lost connection. Okay, good. Edwin, you're back.
I'm sorry,
yeah,
something is wrong with the connection. Yeah.
Any experience with the in-bore MRI biopsy?
No, we do not have any experience with in-bore. I think it's rather cumbersome because you need a radiologist and the patient needs to be lying in MRI for a long time. So really, I think that is really a very tedious thing to do because it's real time in the MRI machine. You spend a long time and patients who are claustrophobic really have a hard time.
Okay, so a question about what you practice in NUH. You have both the Biobot and the precision point. So
Yes.
Is there a selection criteria for both, or how do you choose these patients?
Yes, so basically for the precision point, we usually use that. We have not combined that with a Euronav or other platform. So how we choose is that for patients who need a targeted biopsy, we preferentially use the Biobot. For patients that has who has MRI negative or who choose not to do an MRI, but still need a biopsy, we'll go ahead to do a transperineal precision point biopsy. With NUH, we've done away with transrectal ultrasound. So a transrectal route, so we have 100% transperineal biopsies.
Okay, are you able to share the cost of a Biobot on the cost of the biopsy?
Well, I think it's hard to share this cost because it really depends on the institution, how they cost it. But I think so far, none of our patients have made a huge deal about the cost because it really depends on how you package it.
Yeah. So there's a question here, which I think you've answered this, but just to reiterate the question, the point, what is the over-detection rate of using multiparametric MRI guided biopsies?
Yeah, so I think that
Yep.
yeah, so that is the issue with well, the over detection pertains to the insignificant cancers.
Yes.
Now, I think if you look at a precision point just now, I showed that the precision's trial actually showed the over detection for MRI strategy was 9% compared to the traditional trust biopsy systematic strategy was 22%. Our Biobot series in the biopsy naive, we are somewhere between 8 to 11%, which compares well with precision point just doing MRI and systematic. So I think that's about the percent, and you see that fairly consistent in most series and the Cochrane analysis as well.
Yes. One question about the Biobot. We know that the software itself is proprietary, so
Yes.
you cannot just import that. Has there been any papers comparing Biobot and other platforms at all, to your knowledge?
Not that I'm aware of. I think there's some series talking about the side effects, but there's no head-to-head comparison that I'm aware of at this point. I think at the end of the day, it's not so much we're saying one platform is better than the other. It's really which you are comfortable with. And we find the Biobot very easy to use because of the software. And of course, it's very nice to have the surgeon not sweating over trying to target the lesion.
Okay, thank you, Edmund. So
thank you very much.
That's a very good talk. So we've now gone from a biopsy. We're going to go into the last two talks with the home stretch here. We're going to go on to treatment, and we're going to go for robotic prostatectomy as well as focal therapy. So the next speaker I have to